go to the next speaker.
Okay. So I'm going to invite Dr. Srijana ADHIKARI to give her talk on ocular allergies in children. Dr. Srijana is a consultant at Tilganga Eye Hospital in Kathmandu, Nepal. She has trained in Storm Eye Institute in South Carolina. She has done a fellowship in pediatric ophthalmology from there, and she has been a consultant in this hospital for several years.
Thank you so much, Dr. Sumita and organizing team for this invitation. So I'm talking about the managing ocular allergies in children. So what is ocular allergy? It's basically an inflammations of the conjunctiva, mucous membrane lining the anterior sclera, inner eyelid surfaces in response to any allergens, either persistent or transient allergens. So around 20% of the world populations are impacted by some kind of allergies, and making it the most commonly encountered clinical conditions. It is basically a hypersensitivity reaction and results from various impacting factors, and genetic is one of the very important factors that plays a role in allergy. And on other factors, environmental factors like air pollution and atopy, of course, has some genetic relation, and others are pollen, inflammations, pet hairs, household particles, and the list goes on. There are mainly, how do we classify, because sometimes classification more important in allergy conditions is the finding out the etiology and management, but still we have to know what are the types of allergies that occurs. Like seasonal allergic conjunctivitis is one, perennial allergic conjunctivitis is others, and there is other list: VKC, atopic, AKC, and GPC, the giant papillary conjunctivitis. These are the basically types of conjunctivitis that occurs in the ocular surfaces. Now, what is acute allergic rhinoconjunctivitis? It is the most common form, and mostly it is divided into two types: seasonal and the perennial. Seasonal is mostly because of the pollens that is usually occurs around the spring season, and then the perennial because of the dust mites or fungal, and can occur throughout years or because of many other conditions. So now there is another classifications which has been proposed by the European Academy of Allergy and Clinical Immunological Classifications. You can all go through that, but this is mainly what is there in this classification is: one is IgE mediated ocular allergy, one is non-IgE mediated ocular allergy, and another is ocular non-allergic hypersensitivity. So they have classified in that way, and then the IgG, the VKC comes in the both the subgroups. Now, vernal VKC, which is the most common, most notorious, and very difficult for the ophthalmologists to deal with at times, and it is usually recurrent bilateral external ocular inflammations, mostly in warm, dry climates, immune mediated, associated with the atopy in many cases, and family history of atopy is also there in many cases. Asthma and eczema in infancy is usually the history, and onset usually from 3 to 5 years and resolves around puberty. That is what we usually classically know, but these days the allergy, the VKC, we in our daily practice see in younger children as well, and sometimes in infants also. And it is mostly seasonal, but throughout the year also it occurs. And then it has mainly three types: palpable, limbal, and the mixed types. The palpable VKC is mostly in the palpable region, as the name goes, and then the palpable sometimes it is just a small papillary reactions or papillary conjunctivitis, then can lead to the giant papillae also. And then limbal one, the limbal one has small honotanta dots, but sometimes it increased into some gelatinous like concentric rings in the cornea that can go in up to this severity. And then the complications occur sometimes, like punctate epithelial erosions, shield ulcerations, which is very difficult and sometimes can lead to perforation as well. and then pseudogerontoxin we see, and then keratoconus, which is very, very important and associated with the VKC, and the keratoconus, of course, is very much increasing. At least in our practice, it's increasing a lot, and maybe in other parts also. And refractive error, these are the conditions that is associated with VKC, and the steroid-induced glaucoma and cataract is associated with the treatment with the VKC. And getting to the etiology of allergy, it's a very, very big challenge for everyone. So through better history, to correlate anything that is started and then associated with the allergy is very, very important to find out, and before any tests are done. But if we cannot do anything, then there are certain tests that are available, which is not 100% but may help us, like skin prick or patch test can be done, or if it is not useful, these tests, then we can go further into serum IgG, serum specific IgE measurements, and then the conjunctival allergen provocation test, which in my country also it is not done usually, but it's better to know that it's an allergic, and the allergen is applied to the conjunctival mucosa and then find out. And also it is helpful in finding out the symptoms and respond to the therapy by this test. So these are some of the tests which may help us lead to etiology of the VKC. And then treatment, of course, is mild steroid or mast cell stabilizers, antihistamines, acetylcysteine, and this has the mucolytic properties and useful in the treatment of the plaque formations. And then comes the injections like betamethasone or triamcinolone injections in severe disease can be tried. There are immunomodulators which are quite popular these days, cyclosporin and tacrolimus, but many studies have shown that tacrolimus is better than the cyclosporin. So in my practice also, I prefer to use tacrolimus. And then the biological medications are also there. There are studies which shows that it's very good, the omalizumab, and then other like benralizumab, mepolizumab. These are some of the biological medications that is also coming up for these notorious allergic infections. And then another one is sublingual immunotherapy, subcutaneous immunotherapy. These are some of the things. And then there is another thing which is very much talked about is the vitamin A supplementation. So vitamin D supplementation. There are studies which have shown that the vitamin D, serum vitamin D level is reduced in children with the VKC. So we don't, in practice, we don't give vitamin D supplementations, or in practice also we don't send the children for vitamin D level, but this is something maybe we can think of, because there are many studies coming up that has an association between the vitamin D and the allergic conjunctivitis. And contact lenses is another option. Contact lenses as a therapeutic use, and mostly in those cases where contact lens users and with the VKC can also opt for the contact lenses. And then another use of contact lenses VKC is in cases of the shield ulcer or giant papillary conjunctivitis. Now comes the surgical. The debridement can be done, superficial keratectomy, and there is excimer laser phototherapeutic keratectomy, amniotic membrane transplantation may be required in the severe shield ulcer. So these are the, we go to the surgical options only in a very severe cases. So these are, thank you so much for your attention for this quick update on the allergic conjunctivitis.
Thank you, Srijana. Any
comments?
a quick comment so that.
Yeah. Are you the tacrolimus? Are you using an ophthalmic preparation or the skin preparation?
Yes, this is a very good question. I'm using in my country as a skin preparation. Because we don't have ophthalmic preparations by the government distributors. If we have to use, then we can use from we bring from the India by other
Are you putting
procedures.
it directly on the eye or just on the eyelid skin?
Directly in the eye, but not exactly directly in the lower eyelid. Just apply. We ask the parents to apply a grain, or like a size of a grain, rice grain, to put on the lower eyelid, small amount, and it's stinging. It's stinging, and I think the ophthalmic one is also very much stinging, but it works very good.
It's getting better, yeah. Initially, the initial preparations were stinging, but now they are much better and fairly well tolerated. You put it in the inferior fornix, so you The ophthalmic one, you in the inferior fornix, and you ask the child to close the eye for a little while, so that it remains and diffuses.
Yeah.
And after that, it is generally better.
Yes, and counseling is very, very important. I have found that if you properly counsel, already prepare the parents about these burning sensations and all this, it works very well.
And it's better always to start, I mean, initially have the aggressive intervention so that the congestion, the itching and all comes down, and then you start tacrolimus for a long time. And obviously it would be better, a little better from the reaction point of view, that you have something covering it. I mean, so you can even have artificial tears before you put the tacrolimus, so that it's a little more
Yes,
comfortable.
yes. Artificial tear, after putting the ointment, you ask the parents to put the artificial tear along with that, just after 2-3 minutes, then it helps a lot.
And just on a note of caution, please teach the parents about the side effects of steroids, because steroids do give
Yes.
very, very immediate relief.
Yes.
And chances of on and off use, which lead to other problems, is far more common. So I think as doctors we should take responsibility and probably advise
Yeah.
the parents. And second, please do refractions in these children, because a lot of them do have high astigmatism and symptomatic. They may come to you 4 times in a year, but at least once in a year you should repeat the refraction.
Regarding that steroid part, instead of fluoromethalone, the lotiprenolol would be better for pediatric age group.
Yes,
because they
yes.
don't have that penetration.
Sure, penetrations are less,
Penetration,
but then no
but-
steroid is safe.
Yes.
Yeah,
But
that is
but definitely you can continue lotiprenolol for a little longer period of time than
For the
fluoromethalone or even
tacrolimus,
Dexau,
yeah,
right?
For tacrolimus, it starts taking the actions after the 3 to 4 weeks.
For at least, yes.
At least
So
4, so
initially
before
we should
that,
start from
yeah.
twice a day.
Yeah.
Then we can start with at
Yeah.
bedtime.
Once
Or
a
you
day.
can just start with some like ketorolac or something like that for 2 weeks. Then you can start the tacrolimus. Then it works. We use that way.
Okay.